All right, good morning, afternoon, evening, everyone, depending on where you are. Welcome to the InTouch Health webinar series. My name is Steve Powell, and I'll be helping moderate today's webinar along with Andrei Grujovsky. Today we will be featuring our partner, UC Health, who will present on their experience with operationalizing telemedicine across their healthcare system. Presenting will be Dr. Anya Sanchez. After Dr. Sanchez's presentation, we'll hold a question and answer session. Please submit your questions through the Questions tab located at the bottom of your GoToWebinar control panel. Our Q&A session will be towards the end of the webinar, but please feel free to send in your questions at any time. Dr. Sanchez is the Enterprise Director for Special Projects at UC Health. She was named to the Venue Magazine Healthcare Leadership Award Class of 2014 and the Cincinnati Business Courier's 40 Under 40 class of 2012. She also serves on the advisory board for the Anthony Munoz Foundation, as well as the Cincinnati Museum of Natural History and Science. Dr. Sanchez received her BA from Miami University, her MBA from Georgetown University, and her MD from the University of Toledo. So thank you very much for being with us today, Dr. Sanchez, and that's all for the introductions. Without further ado, I'll turn the presentation over to you.
Thank you, Steve and Andre. Okay, everybody should be able to see my screen now. Again, my name is Anya Sanchez, and it's a real pleasure to be here. It's an honor to serve as InTouch Health's first panelist for their webinar series, so I appreciate that very much. And I will start by saying today that as most folks who have ventured into the arena of telehealth, ours has been a very humbling journey. A lot of the time we weren't exactly sure what we were doing or how to do it, but we've had a lot of activity over the past year and some successes. And so while we're not the biggest or the most technologically advanced when it comes to telehealth, I think our journey is striking a chord with a lot of organizations. So it's a pleasure to share our story today. So a snapshot of our organization. For a lot of West Coasters, UC Health might be confusing, but we are actually located in Cincinnati, Ohio. Our health system was formed in the fall of 2010, but our flagship hospital, UC Medical Center, is nearly 200 years old and has been a part of the community for a long time as one of the first teaching hospitals in the nation. So we have we're a young health system, but we have a long and storied history. Our health system includes services and facilities that span the care continuum. So we have our flagship hospital, we have a community hospital, we have a post-acute care facility, mental health facility, and like most organizations, we also have primary care and ambulatory sites. We're about a $1.3 billion organization. We have over 1,000 licensed beds. We have a large multi-specialty group that's part of our system. And you can see our number of ED visits and admissions and our number of employees, just to give you a sense of the scale of our organization. So I guess to begin the story, our experience with telehealth began, like many organizations, with telestroke. And we ventured into telestroke about 4 years ago with InTouch. And it was a very successful venture. We set up about 10 partner sites, and we have a very well-known, well-recognized stroke team. So, you know, our telestroke program was a great success, but interestingly, telehealth didn't spread to other areas. We didn't see other programs popping up, other types of telehealth programs popping up. And that was concerning to me personally, because we felt from the beginning that, no telehealth endeavor could rest on one single program, that we needed to have multiple telehealth programs in order to have it make sense economically. But it didn't seem to propagate. Last summer, our new CEO identified telehealth as a strategic and operational imperative, and in my role as the Enterprise Director of Special Projects, telehealth was designated to me as a special project. It was helpful that I had been responsible for helping to implement our telestroke program. So all of a sudden, though, our leadership not only felt like it was important, but he felt as though it was a responsibility for us to be a leader in innovation and to be a leader in telehealth. So all of a sudden, our telehealth ceased being kind of a neat stop on the dog and pony show, and all of a sudden it became important for us to figure out how to leverage telehealth to address larger system priorities and to better serve our patients. So another thing that we noticed early on, we wanted to get our arms around telehealth, and we realized very quickly that telehealth programs, this is a slide prepared for us by SG2, a healthcare intelligence firm located in Chicago. This is one of a series of slides, and we asked them to show us where, excuse me, where along the care continuum telehealth has applications. So we figured out very quickly that it wasn't feasible to just create a bunch of telestroke style programs. So, and what I refer to as the pop-up programs. You pop up a program here, or you pop up a program there. We realized that if we were going to have telehealth applications across the care continuum in many different sites of care, we needed to be a little more comprehensive in our thinking, and we had to integrate telehealth into our care delivery model. So, but how? How do we do this? We asked ourselves the same question that many an organization has asked themselves. How do you begin to get your arms around it? How do you build this functionality and in its many applications into our care delivery model? And how do we do it in a way that's economical? And how do we do it in a way that we don't make some big mistakes? How do we leverage telehealth to support our strategic direction? Because we didn't want telehealth to take on a life of its own. It needed to serve a purpose. And how do we do it within our operational context that we have to deal with? So it had to be strategically and operationally aligned. And then finally, if we're thinking about an infrastructure, what should that infrastructure look like? What should it entail? And so we began thinking about what all telehealth programs were going to require to be successful. And that led us a year ago down a path. And so I've tried to compress a year's worth of efforts and successes and failures into the top 10 steps that we felt were critical to operationalizing telehealth at UC Health. So number one, I'm a a big fan of the fact that all business revolves around people. So number one for us was figuring out who will own telehealth, who will support it. So number one here, and our story that I related a few minutes ago, we really needed a clear vision from the top about the role of telehealth. And so I would put out there that support from senior leadership is a precursor to success. If anyone out there has found differently and have been able to go bottom up, I'd love to hear your story. But this was something that we've heard from a lot of folks, and it was certainly true at our organization. It really needed to have support at the highest level. We also needed to have somebody that was waking up thinking about telehealth every day, somebody within the organization that was on point. Because while a lot of people might be involved part-time or peripherally in telehealth, if there's not somebody whose job it is to make telehealth work, it seems to go on the back burner a lot. So we hired a telehealth director, and she is responsible for leading program implementation. She is really the glue for our telehealth department and our telehealth efforts here. The number three, it's important that that person is not on their own. It really does take an extended network of folks, and it requires that that person who is responsible, who's on point for telehealth, really does need a cabinet. And that cabinet really needs to be decision makers, representatives from key areas. We have a steering committee that serves as our cabinet, and they're high-level folks. We have the COOs from our hospitals. We have our Chief Information Officer, our SVP of Payer Relations. So we have high-level representation and people that can really ensure that we don't stall out or become a secondary priority. We also have key end users at the table, physicians and nurses. We usually have the physician champions of a couple of our top telehealth programs that serve as steering committee members. And then does that cabinet, is there unfailing commitment from that cabinet? Because there is going to be setback after setback, and this is the group that isn't questioning whether or not we need to do this, but just how and how quickly and what comes next. I threw this slide in here just because the support from senior leadership is critical for telehealth. I have worked very closely with our SVP of Strategy, our Chief Information Officer. Telehealth is a special project, though, at this moment in time. At some point, once we get telehealth fully integrated into our operational model and it's a part of the fabric of our care delivery, then at that point in time, telehealth will probably report up through our Chief Operating Officer. We've talked to many other organizations, and sometimes telehealth lives in strategy. Sometimes it lives in operations. Sometimes it lives in IT. But this is just a model that we have followed and that has worked for us so far. So number two, ensuring baseline knowledge and establishing shared definitions. So at the beginning of this, we did a lot of research, and I mentioned SG2 earlier. We wanted to really canvas, understand telehealth and its various uses. So enlisting the help of experts that have that perspective, I think, is critical. You might have a resident guru within your organization, but I would suggest that even if you do, you don't know what you don't know. It was easy for me coming into this because I didn't know anything. So it was a blank slate, and we really had to learn from the ground up. But that's been immensely helpful for us. We also had SG2 assist us in getting everyone up to speed. So we brought them in to do a retreat and orient and educate our cabinet. So we had a shared understanding of telehealth. And we very early on established what terms we were using, created a common language and a definition of telehealth, because as you all know, there are so many different terms and definitions out there, and we realized that, to get everyone speaking the same language was one of our first tasks. Now you will see throughout this talk these blue boxes, and what I've tried to do in these blue boxes is note our UC Health kind of an example from our organization. So I have our telehealth definition shared here, and it's very similar to the SG2 definition of virtual health, but we decided to take a very broad definition of telehealth because we didn't want to pigeonhole ourselves or miss any opportunities, because the applications of telehealth are only going to continue to expand. This is another slide that we've used frequently, showing kind of the continuum of applications and end users for telehealth. Everything from the clinician to clinician there on the left side, to the provider to patient, and then finally on the consumer-driven. And there seems to be the most development on the left-hand side of that continuum, and we're trying to move toward the right. I think there's a lot of promise in consumer-driven applications, but there's also a lot of opportunity in the provider-to-patient applications. Another early thing that we did was we aligned the mission and vision of telehealth with that of the organization. Telehealth can frequently become its own thing. There's a lot of amazing technology out there. There are a lot of things you can do, and it's really easy to go down a path of something that you can do because it's possible. But we wanted telehealth to serve the priorities of our organization. So when we created our telehealth mission, you will see it's in that blue box, it's to improve the health of our local community and region and support our academic mission. And our mission for the organization, for UC Health, is very similar to this. So you can see it's, we didn't try to recreate the wheel with our telehealth mission. It is serving our organizational mission. And our vision here, our future state that we're striving toward, was that we wanted to become a leader in the successful application of telehealth technology in pursuit of our mission. So you notice there, it doesn't say we want to be the biggest. It doesn't say that we want to be the most technologically advanced. We want to be a leader in the successful application of technology in pursuing our mission. Number 4, another early thing that we did was we determined what our telehealth goals should be. And again, we looked at our organizational priorities and our organizational goals. So we leveraged our cabinet to help us build those goals. You can see there I mentioned again our steering committee. And our steering committee was created in large part to support the development of solutions that address strategic imperatives. So, we have the pop-up programs, which are great when they come to you, but we also wanted to make sure we were pursuing a more proactive model of creating programs that addressed enterprise-wide strategic imperatives. So another thing that we did is, in developing these telehealth goals, we wanted to identify the problem first and then design the solution to address it. This second blue box is actually I took from our program matrix. So we maintain a program matrix of all the telehealth activity that's going on across the system, the programs in development in the various stages. And the column headers, it's just a simple Excel spreadsheet, but the column headers start with organizational priority. And then from there, what are the telehealth goals that serve that organizational priority? And what are the telehealth tactics that serve the goals? And then finally, what are the pilots or telehealth programs that serve those tactics? So we can look at any telehealth pilot or initiative that's underway in our organization, and we can trace it back to say, yes, this is the strategic priority that it is serving. And then finally, for those top-down goals, when you're going from the top down to identify what those strategic needs are, it is so critical to have owners, to have buy-in. So that is a very early step in identifying our telehealth goals, is that we needed to identify who those champions would be. Process. We wanted to enable program development to move forward, and it can be very haphazard, especially the more programs that you have that are in development. And if there's not a standardized process, people just kind of go at it the best way they can. And so you can have a lot of well-meaning loose cannons out there. So we created a process for program development. This helps because you don't have loose cannons, but you also have, people aren't having to reinvent the wheel. So it's process is not really seen as a barrier. It's really seen as a way to support programs, and folks really seem to appreciate having some guidance and knowing that there is a process to follow to get a new program up and running. We built some tools to assist teams in developing new programs. One of the tools that seems to get a lot of interest is our telehealth toolkit. This wasn't a new idea. We've talked to a couple of organizations that have devised telehealth toolkits, but we wanted a way to extend our ability to help new programs. So if you have a program team that's wanting to get moving on a new telehealth program, we didn't want, and sometimes they don't want to have their hands held at every step of the way. So we created this toolkit to guide program design. And I'll share a little more on that in a moment. We also have created a training guide template that can be used across different programs. So the process for program prioritization was also important. So we are fortunate in that we are at a place where we have so many programs that are popping that when a program pops that is exciting and interesting to that group, but it may not be aligned with our strategic priorities, we have to be able to prioritize our efforts. So the steering committee helps us to prioritize our programs for development. And I have a little flow chart that I'll share in a moment. But first, I wanted to show a snapshot of our telehealth toolkit. Again, I'm a simple person. We just created an Excel spreadsheet. It's multiple tabs, and we actually leveraged our telehealth experts in-house. So there's a tab for each key area of telehealth. There's an IT tab. There's a financial tab. There's a legal tab. There's credentialing. So a program team can use this toolkit then to guide their development. Probably the most important page of the toolkit is the face page. This is a picture of the top of it. But on that face sheet, it outlines the big questions that we want to answer in our, in our first few meetings with a group. We are looking at, we're moving toward a point where we'll hopefully be able to share our toolkit with organizations. That seems to be one of the biggest requests we've been getting lately, is to share our toolkit. So we're working towards being able to share our toolkit with other organizations. If you're interested, feel free to reach out to me. We're even considering productizing this toolkit. So process for program prioritization and program development. So programs tend to evolve through two different avenues. The 1A is a new program concept is developed via our steering committee through our strategic planning efforts. It's identified as a system priority. When that happens, the first thing we do, that's step 1.5A, is that we identify the team for it, because that really does have to come. We don't want to build a program and then figure out who wants to do it. The other avenue is, and this is the more common one, probably many of you have found, the new program concept is initiated by through grassroots. We refer to this as grassroots effort. It's a clinical team. They say, gee, I wish I could do follow-up with my patient after they get transferred to LTAC, or what have you, fill in the blank. So they want to pursue this through grassroots. Whichever avenue that comes through, one of the first things we do is the telehealth director interfaces with that program team to talk through design and to do an initial evaluation. Then our telehealth director brings those viable program models. I serve as the chair of the telehealth steering committee, so she and I talk through those various programs. And the viable programs I then bring to the steering committee to get their thoughts and input. And the steering committee provides me with recommendations on and recommendations as to how to prioritize that program based on two things: strategic fit and value, and the ease of implementation. Let's see. Once we get those programs that have been vetted through the steering committee, then I can take those programs to the system level leadership for approval. And once we have approval, the telehealth director begins the formal implementation of those approved programs, and that includes working with the implementation committee, which I'll talk more about in just a moment. So number 6 is your implementation network. So the implementation, or operationalizing a telehealth program, requires the input of many experts, many functional areas. Some of the ones I've already mentioned: legal, IT, scheduling and intake, billing. So what we did was we created an internal network. So the individuals can interface with one another, and so that new program teams can come to the implementation committee so we can talk through implementation of high priority programs. Our implementation committee meets once a month, And we have an agenda every time, and our top priority telehealth programs are what constitute that agenda every month. Let's move backward. This is a snapshot for those of you that are visual. This shows visually how the thing hangs together. So you've got at the top in that blue box your organizational strategy and integration, and the Telehealth Steering Committee is that group. They're responsible for figuring out strategic direction, figuring out how to integrate telehealth into our care delivery model. The Implementation Committee is that cloud in the center, and the only full-time telehealth person on the Implementation Committee is the Telehealth Director. Our Telehealth Director chairs the Implementation Committee, and all of these other boxes represent other functional experts that participate in the Implementation Committee once a month. Then in the green box in the bottom, those are the operating units and departments, and those are where your program teams are. So those are kind of the grassroots efforts. Sometimes new programs come from that bottom box, the grassroots. Sometimes new program ideas come from that top box, but either way, they both have to come to implementation to get set up. So then hurdles. Hurdles, how do you get over them? Because they pop up, and if you're not ready for them, they can slow you down. It can be very frustrating. So we have a low threshold now for, when we get into a situation where we go, oh wow, this IT situation is sticky, we're going to have to think about this. We have a pretty low threshold for spinning up kind of an ad hoc committee or a task force to figure out a solution to that problem. And it might meet once a week, it might meet once a month, but that task force meets to really put a lot of attention to solving that problem. So it's important to ensure that the correct people are included on that task force, and to make sure that they are connected to the larger telehealth infrastructure. So you're going to want to make sure that your steering committee, your cabinet, that your implementation committee, that your senior leadership, whoever needs to know is tied into this. So it's not just an isolated group. And I can't tell you how many times for how many different purposes we've had to do this over the past year. So IT, building the IT platform with the system in mind and with the future in mind. So for us, telehealth, we kind of are from the philosophical school that telehealth is technology enabled, not technology driven. And I think that's a really important distinction for us, because we wanted, we didn't want the cart to get before the horse. Our IT department has been incredibly supportive, from the CIO down to the front lines. So we partner with the IT department. They are involved at every level, but they're not the ones that are determining the direction, the strategic priorities, the operational needs. We work with the IT department to establish guidelines to enable the growth and development. We didn't want to get to a place in 3 years where we had 40 different telehealth technology vendors that we were using, and that we had patient health data living in multiple mini EMRs all over the place. So we put some guidelines around requirements, and we also, as part of our process, made sure that the IT department was involved very early in vetting vendors. And we do have preferred vendors that are part of our standard platform, and we try to really limit that and vet out new ones that we add. Finally, we really felt as though this is something that we need to be as progressive as we can in developing some of these capabilities in-house. We think that this is something healthcare organizations will be expected, capability that healthcare organizations will be expected to have in the not too distant future. So where possible, we're trying to figure out how to build telehealth capability into our organization. But we do recognize there are key areas that it's really important for us to have trusted, high-quality partners that we can outsource with. So this is another piece. This is critical from a culture standpoint, driving innovation and enabling experimentation. So we learned early that the innovators in your organization kind of have it in their blood. They're out there, they're trying new things, they're fascinated by new technologies, they're interested in learning new ways to be efficient, provide better care, and they can be the gunslingers in the Wild West. But we decided that they could also be really powerful engines and advocates of our telehealth journey. So we have really brought them in to our steering committees. We've brought them in and involved them in the process, and they really help accelerate our progress in many ways. So in addition to identifying your innovators in your organization, we are trying to broadly communicate the importance of telehealth technology and the role it's going to play in the future of care delivery. So everyone, even if they're not a techie person that has to have the latest iPhone, everyone understands this is the future, and this is why it's important and how it's tied to our mission of serving our patients. Number 3, it's important to support the development of small-scale pilot programs. So, our implementation committee, one of the key things that they do is they help those program teams overcome barriers, get the legal contracts, figure out an IT solution, figure out credentialing. So we feel it's an important duty to help those pilot programs be successful. And we also expect some failures. And fortunately, this is a growing phenomenon in our organization, that we know that it's important to be innovative. We know that it's important to try to change and evolve. And with that process, there are going to be some failures. And so we're trying to reduce the risk of innovation within our organization. Now, that doesn't mean that it's willy-nilly. It's really critical to have accountability and to have, that's why we have a lot of these systems and processes in place, to ensure that that accountability is there. But we're trying to grow a non-punitive culture. So folks that have good ideas and have a desire aren't afraid to try something new. And we're trying to celebrate and reward the innovators, identify them, make them visible. In fact, one of the things we're doing is we have created a Care Delivery Innovation Prize. We just rolled that out earlier this summer, and that process is going to actually award a cash prize to 2 of the most innovative telehealth programs. And we've received so much interest from across our organization because of this prize. And what we've discovered is that a lot of people have wonderful ideas and are interested in figuring out new and better ways of doing things, But they also have day jobs. They also have, 6 fires to put out today, and it's really hard to take the time and make it a priority to create something new or design something. So we found that this innovation prize has surfaced a lot of those folks because all of a sudden there's a reward for doing so. Number 10, determine what constitutes success metrics. So with this, we try to start with the end in mind always. Whenever we're talking to a group that's interested in a telehealth program, always as part of that very first meeting, in addition to what do you want to do, why, who's involved, we also ask, how will we know if this has been successful? How are we going to measure success? So, number 2 is identify metrics that ensure you can track progress over time and that answer the question why. So if you're building a telestroke program because it's going to enable you to provide better care to underserved areas, better stroke care in underserved areas, well then maybe you can look at door-to-needle times for those institutions, and are you able to reduce door-to-needle times? With metrics, we're trying to support them centrally, but ensure local ownership. So while there are some metrics that, we've actually put together a little dashboard, a performance dashboard, and we've created it as a template. So each telehealth program team can have the dashboard, and there are certain metrics that are common that we want to measure across every telehealth program. But then there are metrics that are going to be specific to a particular telehealth program as well. So we want to have the program teams feel ownership of their metrics and be tracking them, determining what the metrics should be, and then tracking them. Transparency. We are planning to bring program teams to present their dashboards to our steering committee regularly, and we'll be doing that for the first time here in a month or two, having 2 to 3 programs present their dashboard for the steering committee. We are also working to ensure that our telehealth performance metrics support our enterprise goals, and I'll show you what that looks like in a moment. Finally, a final word here is to keep it simple. We're really, physicians, clinicians in general love data, and it can, pretty soon you can have a 2 or 3 page performance dashboard that is fascinating to the clinicians, but isn't necessarily practical in terms of monitoring those key questions that you created the program for in the first place. So keeping it simple is very important. This is just a little snapshot to share. In the left-hand column, we have our enterprise goals, just at a high level. And we have then our common metrics, and what we mean by common is that every telehealth program, we expect to track these things for every telehealth program. But then there are program-specific metrics, and those are for each program team to determine. So perhaps the telestroke program would list door-to-needle times under their program-specific metrics. So then bringing it together, we created our telehealth department this spring, and we created it in order to accelerate our strategic and performance goals. We created it in order to reduce variation across our telehealth programs and reduce the amount of time required to launch new programs. We created it to bring innovative care delivery models and into our system, and we also created it to be able to realize the return on investment through our telehealth programs. And that return on investment might be financial. It also might be in terms of efficiency. It might be in terms of patient satisfaction. But that's kind of why the department was created. And in a nutshell, the telehealth department consists of a small group of dedicated personnel who are really the integrators and activators. It consists of, as I've described earlier, an extended network of involved experts and support people. It consists of established processes for program development, barrier removal, and it also includes an approach to innovation that enables and drives small change. So is it working? Our progress to date, this is a glimpse at our development pipeline. We think of our development in terms of our design phase, an implementation phase, and then our active pilots. Right now, we've got 6 programs in design, 6 in implementation, and 3 active pilot programs. This does not include our telestroke program, which has been up and running for some time. And the way we distinguish between these phases is that the design phase is really those early discussions that just focus on the program team, and we work on the toolkit, the face, completing the phase sheet, answering those big questions. And it doesn't take a lot of time if it's a serious group and if it's a good program, a solid program idea. The implementation phase takes longer, and that is where we begin to loop in the implementation committee. And this can take longer, anywhere from 2 to 6 months, depending on what hang-ups you have. And there are several variables that can play into the determining that timeline. Our active pilots are the programs that we are actually seeing patients through that program. We're actually using the program. And the pilot length may vary. And I've been asked the question before, how long do pilots last? And the answer is that it really depends on the metrics that you've selected to measure success. And it also depends on what your early results are. If you do a few trials and the providers hate it or it's not going well, then that might be a very short-lived pilot. If they love it, then it might become a permanent program. You might expand it and just grow it from there. So another thing I wanted to share in terms of how we're doing is our infrastructure working. I created this. I showed you the slide earlier. We created this system because we wanted to be able to build programs across the care continuum, different models, different end users, different sites of care. And when we plotted out our pilots across the care continuum, we didn't do this on purpose, but we were all kind of thrilled to see that our pilots really do span all these care models and all these sites of care. So this is reassuring to us that the system we've built is enabling us to build telehealth in all of its various applications into our care delivery model. So next steps. We really want to move from reactive to proactive. So to some degree, we still kind of feel like we're doing pop-up programs. We've got all these pilots, but it's usually from groups coming to us and saying, we want to do this. And we say, okay, great, we'll help you. So we've got all these bright ideas, all of these flames that are kind of springing up across the organization. We really want to move to a place where we are proactive. We really want telehealth to become something that is self-sustaining, it's driven from within, it's efficient, it's really serving as kind of a power plant. It's providing the means to our providers to serve our population. So this is where we're headed. Lots of exciting things that are coming up over the coming months for our organization. I hope that this has been helpful for you all. I'm happy to field a few questions. I will throw in a plug, though, before I turn the phone over. I'll throw in a plug for a telehealth conference that we're doing next March. It's going to be our 3rd annual telehealth conference here in Cincinnati. So wanted to throw that out to the folks on the line. So with that, I will turn it back to Steve and Andre.
All right. Thank you very much for the great presentation, Dr. Sanchez. We had several questions come in while you were speaking. I think Andre's ready to address some of those. Andre?
Yeah, thanks, Steve. So Dr. Sanchez, we had a couple of questions come in. One of them was, does UC Health view telemedicine and telehealth as one and the same, or is one of these broader, and how do you define that, and do you use that in defining your strategies?
Yeah, that's a fantastic question. And that was one of those definitional questions that we had to figure out early on, because we wanted to, a lot of times telemedicine refers to kind of the telestroke model, the physician to physician, but we wanted to take a much broader definition. We wanted to look beyond that. Telehealth is a much broader definition, so we started using the term telehealth, but it was interesting because even early on when we were using the term telehealth, folks would say, well, what about this and what about that? And so I think even with a broader definition, people weren't clear that it includes things like, if you remember our definition on one of the early slides, our definition of telehealth is really connected care services. So anything where you're connecting people across space or even across time, because you have asynchronous telehealth programs as well. So yes, telehealth is much broader, a broader definition, and telemedicine is a bit narrower, so that's why we speak about telehealth here.
Great, thank you. So we had another question coming in from Josh. The question was, for those programs initiated out of the strategic direction versus a clinical champion coming to you with telehealth idea, how have you approached the proposal for telehealth to your clinical/service line leaders? Do you have any lessons learned in taking a program from design to implementation?
Right. So when you identify a top strategic priority and you say, wow, we really need, we need to build a telestroke program. This is important for our organization. How do you then take that out? And I would say in those situations, now for our telestroke program and for most of our programs, we had just the opposite, and that's the easier one when they come to you. But for the ones that we've identified now, we are really spending a lot of time working. I'm a physician by background, so I really enjoy working with physicians and talking to them about their needs. It has to make sense for the clinicians. It has to make sense for the folks providing care. There have been a few models that I thought were really exciting for us, and we should move into them. But then I would go to that department chair and say, what about this? And they'd say, no, that wouldn't work. That wouldn't work in the way we practice care. And so, we have those discussions early and involve those providers early, whether they're physicians, nurses, social workers. You've got to involve the end users early and make sure you've got buy-in and that they're enthused about it, or else you risk building a program and then not having anybody want to use it.
Great, thank you. We have time for, I think, one more question, and then we'll wrap up with providing some contact information, which you guys will see on the screen. So we had a question from George, and the question is about your IT platform. George believes that many people falsely believe that if you equip physicians with iPads and Skype, you now have a complete telehealth system. Can you briefly describe the technology you use to design a general telehealth infrastructure and communication network that integrates your multiple telehealth programs?
No. Oh, that's a really complex question. I can. I'll do my best. But basically, you know, and this was months and hours of work with our IT department, because we've got our electronic medical record. We use Epic. You know, we work with InTouch and have for a long time. We work with a few others, but we wanted to make sure that they were integrated where possible. You know, they have to be HIPAA compliant, so that's the thing about Skype, is that you've got to make sure that your technology meets all of the standard requirements of your organization. And then, you know, integration of all of that IT is kind of the holy grail. But we've learned that interoperability doesn't exist yet. It will at some point, but it doesn't yet. So integrating the various technologies is time-consuming. So you've got to be selective. That's one of the reasons we try to be selective in which technologies we use, and try to limit them to a small number. And I hope that answers your question. That's a big question that I'd be happy to take offline with George.
Yeah, it is a big question, and I appreciate the response in the short time frame. And there were a few more questions that we didn't get answered. One of them I did want to mention was a lot of people have asked about the telehealth toolkit and training guide. I will pass those requests along to Dr. Sanchez, and we can take that offline after the webinar. So Steve.
All right. Well, we would like to give a big thank you to the University of Cincinnati Academic Medical Center and UC Health for presenting today. Thank you very much for your time today, Dr. Sanchez.
It was truly my pleasure, and I wish you all the best in your telehealth journey.
Excellent. For additional questions or information, please contact us at questions@intouchhealth.com or contact Dr. Sanchez directly at the email address that has been up on your screen. And please visit our website to see a list of upcoming webinars in our series and to sign up today. Thank you all for joining us, and we'll see you next time.